Well, thank you very much, and again for your courage in being here today and your incredibly persuasive and articulate testimony. Thank you. And then I guess for anyone on the panel, cede to others, but what is the process necessary for a person who's been prescribed psychotropic drugs to get off of them? What needs to happen medically? Does it require a doctor approving a build down or getting off? Could you maybe address that?
Sure. I think they need to find a doctor who is interested in doing that.
Do you mind speaking to the mic,
Yeah,
please?
they need to find a doctor who's interested in doing that and willing to do that. And there are those psychiatrists around. And it's a pretty simple matter. You begin one medication at a time, and you taper it down slowly over perhaps a couple of weeks, and see how things are going. And if that's going well, you start with another. I spent most of my time, actually, I worked for 9 years in two of Seneca's programs that are the highest level of care in California, CTFs, locked adolescent units. And I spent most of my time taking kids off of medication because many of the children had been in hospital and would come out on a lot of meds. And I spent a lot of time taking them off.
Do you need a court order to do that?
No.
It can be done under the doctor's supervision.
Just to put them on, yeah.
Thank you. Any others?
Well, I just wanted to add that practically speaking, again, a lot of this goes back to the caregiver because as Iris mentioned in her testimony, even though that is the legal reality, the practical reality for young people who are living in the home of somebody else or in a facility is that you feel as if your caregiver has full control over whether you take the medication or not. And so you're literally punished often in many facilities, like drop down to a level 0 and taken basic privileges such as visitation, being able to use the phone, being able to walk outside, are taken away from you if you refuse to take medications or if you decide that you're taking yourself off. Many young people actually see a psychiatrist that is contracted with a particular facility, and so it's difficult to get a second opinion, to have that access that, yes, theoretically it's available, but when you're in care, it's very hard to actually find it. And I mean, one of the other things I just wanted to mention was that years ago, this was actually over a decade ago, there was a project that was done in California called the California Permanency for Youth Project. And in that project, they were working with young people who are in the highest level group homes, in level 14 group homes in California, and they were doing family finding for them. And once they found that they were connected with sort of their family members who loved them and cared them and oftentimes gave them access to activities that they had had no access to in facilities. And we're talking about, we were just recently this week dealing with a group home whose recreational activities were field trips to Target and Michael's. I mean, that's the extent of activities, like let alone, like Iris mentioned, opportunities to really engage in youth development activities. But they found that once they connected them with family members, not only did their need for the psychotropic medications disappear, but actually sort of the whole diagnosis fell apart. That young people seemed much more healthy than they had ever been in care and weren't presenting symptoms. So I know it sounds very squishy to say that like sort of love and parenting and nurturance cures, but I think it's exactly what the research is telling us, that until we are able to provide that to young people, that we are going to continue to see symptoms, and because of the structure of our system, we'll continue to have young people who are prescribed because we don't have the adequate treatment.
Could I just comment on that? I totally second it. It was sort of the most amazing thing to me when we began to use family finding and would find a relative who lived in New York, say, and could only communicate by telephone once in a while or email. A child would have hope and they would begin to work on themselves, and diagnoses fell away. There's much less need for medication. So I think it just underlines relationship, what you were saying before.
Well, and just then a final comment on that, the amazing series in the San Jose Mercury, I think Karen Desaw, there's one of the sections talks about the incentivizing of psychiatrists to prescribe psychotropic drugs by the drug companies. And I don't know that this is the section of our hearing to discuss that, but maybe, Doctor, have you been subject to those promotional efforts, and how do we avoid there being a monetary incentive for people to prescribe these drugs?
I think there has to be national legislation about that. I went to one of those wonderful dinners they offer, and I was so disgusted by the whole process because it turned out it wasn't really an informational dinner. It was a promotional dinner for the medication that he was being paid to. And actually, we know that the drug companies actually write the script for those talks. And yeah, it's awful. And I can't give you a number, but the number of doctors, just practicing physicians, who are getting money directly to prescribe drugs is astounding.
There's actually,
And we're going to have to make it very quick, please. Go right
I just
ahead.
wanted to say there's actually one state, so you mentioned national
If you just
legislation.
speak in the mic.
There's one state, Vermont, that does have a legislation on the books about restricting those types of handouts and pharmaceutical tactics for marketing that are non-informational and that are more just marketing based. So that's the place to look if that's what you're looking for.
Thank you.
Thank you so much. I would like to be able to turn it over to Senator Hancock and thank her for her many years of advocacy as well. And we're grateful and honored that she's here today.
Well, thank you so much. I have to say, I feel this actually very deeply. I've had the ability, the privilege really, of having two former foster youth interning in my office, one of whom, Sade Daniels, was written about in the San Jose Mercury News article. She's on her way now. Is she? She's coming for... I couldn't believe, I was looking out in the audience because I couldn't believe she wouldn't be here. But also, I can remember going to speak when I was in local government at a group home in my community and wondering why the kids didn't seem to be paying any attention. They seemed to be sort of nodding off. And what moved me so much then was that the one time everybody kind of snapped to attention was when they asked me about what happened if you became homeless. And I suddenly realized every single one of these kids is waiting to turn 18 and have that happen to them. And that's like a real thing. So I'm very interested in what we can do about this. And my feeling is psychotropic drugs, we're talking about the tip of the iceberg. Just listening to the four of you speak, what kind of assessments do we do when children come into a foster care system? What kind of individual plan do we have so that that child gets what they need? We really have minimum wage people working in these youth homes. What's the staff to youth ratio? How are they trained? How do we recruit foster homes for kids to try to find, because I've had so many descriptions of the young person with the suitcase on the porch when they turn 18, or living in a place where nobody really cared about them, even if it was only 5 young people in the home. I also had a situation when my own children were in parent nursery school where a child was killed by a foster mother. And it was so traumatic for all of us because somehow as little middle-class moms, it hadn't occurred to us that the things we were seeing meant that abuse was going on in the home. So obviously, there's a huge amount we have to do. And I remember kin care, that whole business of reaching out to families and how we train them and support them for doing that. I really wish that you all could tell us 5 things that we need to do to get a good system. Because I think the commitment is there. It's very hard to figure out what are the things we need to do. And to go back to Mr. Monning's question, I was thinking when you said national legislation, well, California tries to be out in front in a lot of areas. And if Vermont has actually done something like this, that's like a real thing that we should think about doing. So, I can't thank you all enough for being here. You're incredibly knowledgeable and eloquent. but can you, and I guess, can you give us somehow, coming out of this hearing, 5 things that we can work on in this legislature that would profoundly change the system, let alone take care of this particular problem?
I think you're going to hear a lot in Section 5.
Section 5?
Yeah.
Okay,
I think that's,
good. Yeah,
that might be a
but
start.
innovative models, we want to know how to bring them to scale and who has to do it, right? Yeah.
Sure.
And if you don't mind, and I do apologize, I don't want to interrupt, just because we have
4 more panels.
yeah, so I just want to make sure that we want to hear your response, and if you don't mind, 2 minutes?
Very concise.
Yes, thank you so much.
So, I mean, I'd love to have a little bit more time to come up with the 5, because I feel like I'm not going to
Please.
give you 5, and I don't want to lose out on 2. But one of the things that I think is really important is, given what we know about group care, I think it's very important to do, in addition to sort of the basic restrictions on putting children in group care and getting children who are in group care who do not need to be there phased out and immediately put into family homes, and sort of providing those services and support, which is part of what we've been doing in the Quality Parenting Initiative, working with 20 counties here in California. I think another thing that's really important is to be monitoring higher level group homes where we have very high rates of psychotropic med prescriptions, and making sure, number one, that they have a solid plan of alternative mental health services that they are offering, and that plan has been approved and vetted, and that we audit them to make sure that, in fact, they are providing those type of mental health services, and that when we see there are facilities who have rates that are excessive, that we go in and do a very intense audit to make sure that they can actually provide the care and supervision that's necessary for the children in the facility, so that we don't have facilities that have young people who have really intensive needs doing things like providing activities like field trips to Michael's and Target, but actually have opportunities to get involved, to have a voice, to do basic things like go to school outside of the home, to participate in debate, cheerleading, football, all of those things.
Thank you, and I'm not
Thank
trying to
you.
rush you, and I apologize.
Yeah, no,
My
no.
goodness. Thank you very much. Please.
I don't have the time to come up with 5 things right now, but I have one recommendation that I think is really important and critical. I think that every young person that's on psychotropic medications needs to have an advocate that they trust, that they're not worried is connected to the system in some way, that if they're going to tell them something or express something to them, they shouldn't have to worry that that'll be used against them in any way. So this person might be a peer, might be somebody closer to their age, but I think there needs to be some kind of program to provide that real trusting relationship with an advocate for each person taking psychotropic medication. Everybody that's seeing a psychiatrist and facing the possibility of being put on medication.
It's interesting.
Yeah, no, very much appreciate it. Thank you. Please.
Thank you, Senator Hancock. This is what I've studied, is what does work in other states and in some of the counties here. Washington State provides a tool to social workers that can actually identify the therapeutic, community-based, and school-based services that would meet the symptoms. They don't have to know anything about diagnosing. They can type in the behaviors they're seeing, and the tool says, these are things that would work, and then they can consult with a provider. But it sort of curbs off that first line is to call the access line to get an appointment with a psychiatrist, where many of the places that we're sending foster children, it's a 15 to 1 hour visit without a therapeutic relationship developed. And many children leave those situations with a prescription that may or may not be filled. So we like that tool that Washington provides as a way to curb first line approach to meds. Ohio identified with their data that their prescribers, they don't have psychiatrists in their state. They were mostly physicians. What they then did, they said, hey, we're going to identify those physicians that are doing the risky practices. We're going to educate them. There's an online training where you can have continuing medical education credits. So they're giving them credits to their future. They're paying them for their time, and they're training them to reduce that. But they identified their problem using data. And then Arkansas requires screening and monitoring appointments for children that are taking psychotropic medications. And what that does is, if there are the side effects, they're noticed sooner. They're not noticed. In California, we have 180 days between court appointments. That's 6 months. In 6 months, you can gain a lot of weight. You can have that stuff happen that without that appointment, we don't know. So we like those models, and I could keep going, but I'll stop there for time.
Thank you.
No, thank you. And I am not at all, hopefully I'm not coming off as pushy, and I apologize just because we have a panel. But what we'd love, and Doctor, want to hear from you as well, is that we'd love to be able to have it in writing as well, if that would work.
Of course.
And then I would like to be able to say we're going to have a hearing on the same exact subject later in the fall, where we're going to be following up as our goal of not waiting another 10 years. So please, Doctor.
Just briefly, I think it's, in a more global sense, we need to shift our thinking away from the primacy of psychiatric medications towards relationships. So any of the, say, crisis services that would help a child, medication would not be the first thought. I do think we're going to look back on this era of great enthusiasm for psychiatric medications, which are very nonspecific in their actions, and either scratch our heads or hang our heads. Because I think in 10 or 20 years, we'll look back and just wonder, what were we doing pouring this stuff in? And just a lot of societal pressures to do it. But I think we need to be thinking in terms of relationships, because that is what makes kids better, and that is a big area, I know.
Yeah.
But I think we'll end up with foster kids who are productive and happy and healthy, and not fill the prison system, which is where a lot of them are going to end up without that kind of help.
You're absolutely right. Thank you, Doctor, very much. Senator Hancock, any other questions or
No,
comments?
thank you.
Again, thank you so much. I just have one quick question, actually two. Ms. Rodriguez, what has changed since you last spoke on this topic 9 years ago?
Unfortunately, not enough. I think one thing has changed is the awareness of psychotropic medications. I think that it's not news to anybody anymore that young people in foster care are on psychotropic meds at a high rate. I think another thing, though, that has changed is that in the policy arena, I think that what Anna mentioned earlier, which is that there's much more receptiveness from all sides. And I think a big environmental context is that we are talking about this issue sort of under the umbrella of group care reform that we have engaged in, because we knew that not only was there a huge fiscal cost to the state, but in my mind, I care about the fiscal, but I care about that much less than the opportunity cost, and that we have known for decades that the lives and potential of young people who, just like Iris is a wonderful testimony to that, who could have been sort of having a different life much earlier, that we're squandering that when we put young people in congregate care settings. And I'll also say the research has changed. We now know much clearer than we ever knew before about developmentally what children need to heal past trauma. We know much more about what the impact of trauma is, and we know that the healing factor, that parenting is actually, it's the most effective intervention that child welfare can offer, period. Yet we have not realigned our policy and practice around parenting.
Absolutely.
So that's my hope.
No, thank you so much. And I'll hold my other question to the end. Again, Senator, just as we close, any closing comments on this panel?
No.
Okay.
So thank you again, truly. And anything we can get in writing will be helpful.
Absolutely.
For our future.
No, thank you so much, Senator, and again, all your advocacy as well. And we want to say thank you for being here today. Let's give our panel a round of applause, and please say thank you.